ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਐਂਡ ਵੈਲਕਮ ਟੂ ਸੀਜੇ ਸਿੱਧੂ ਸ਼ੋ। ਜਿਸ ਤਰ੍ਹਾਂ ਤੁਹਾਨੂੰ ਪਤਾ ਹੀ ਹੈ ਕਿ ਮੇਰੇ ਸ਼ੋਅ ਦੇ ਵਿੱਚ ਜਾਂ ਕਿਸੇ ਪੋਲੀਟੀਸ਼ੀਅਨ ਨੂੰ ਜਾਂ ਕਿਸੇ ਕਮਿਊਨਿਟੀ ਐਕਟਿਵਿਸਟ ਨਾਲ ਤੁਹਾਡੀ ਗੱਲਬਾਤ ਕਰਾਈ ਦੀ ਹੈ। ਪਰ ਹੁਣ ਜਿਸ ਤਰ੍ਹਾਂ ਤੁਹਾਨੂੰ ਪਤਾ ਹੈ ਕਿ ਕੋਵਿਡ-19 ਦਾ ਜਿਹੜਾ ਇਹ ਚੱਲ ਰਿਹਾ ਟਾਈਮ, ਇਸ ਦੇ ਵਿੱਚ ਨੋਰਮਲੀ ਮੈਂ ਲੇਟਲੀ ਡਾਕਟਰਸ ਨਾਲ ਗੱਲਬਾਤ ਤੁਹਾਡੀ ਕਰਵਾ ਰਿਹਾ ਹਾਂ ਤਾਂ ਕਿ ਉਹ ਤੁਹਾਨੂੰ ਇਨਫੋਰਮੇਸ਼ਨ ਦੇ ਸਕਣ ਅਤੇ ਤੁਸੀਂ ਜਿਹੜੀ ਪ੍ਰੋਪਰ ਪ੍ਰੀਕਾਸ਼ਨਸ ਲੈ ਸਕੋ ਅਤੇ ਉਸ ਦੇ ਨਾਲ ਨਾਲ ਤੁਹਾਨੂੰ ਇਨਫੋਰਮੇਸ਼ਨ ਵੀ ਮਿਲ ਸਕੇ। ਸੋ ਬੜੇ ਖੁਸ਼ੀ ਦੀ ਗੱਲ ਹੈ ਕਿ ਸਾਡੇ ਵਿੱਚ ਅੱਜ ਸ਼ਾਮਲ ਹਨ ਡਾਕਟਰ ਇੰਦੀ ਸਹੋਤਾ, MD, MSc, CC, FP. He's a staff emergency physician at Sinai Health System and Scarborough Health Network in Toronto. And he's also ICU clinical associate at Surrey Memorial Hospital. And he completed his medical school at the University of Calgary, and then went on to complete his family practice and emergency medicine residency training at UBC here in Vancouver, and also runs a non-profit organization. I was really impressed to see that 1,000 meters above. So that's amazing. We might able to, if we have a time, we talk about that as well. And he have a time to spend in Ethiopia, Ladakh, in northern India, and the people living in a high elevations and how their needs are different than our needs. So it is a very, very interesting resume. It's a pretty long. If I read, you will not able to listen to Dr. Sahota. So welcome, Dr. Sahota, at a CJ Sidhu show.
Thank you very much, Mr. Sidhu. I'm really happy to be here and happy to be talking about COVID with everybody. As you know, it's become a massive issue around the world, especially here in Canada. So I'm happy to be able to talk about where we're going to be going moving forward.
So, Indy, let's start with a little bit of intro. Whatever I told, if I missed something, tell about yourself. I know you were born in England, and then you were very young when you came to Canada, and your journey started in the education field. So tell me a little bit more about you.
Yeah, sure, Mr. Sidhu. So I was, as you mentioned, I was born in the UK. I moved to Canada when I was very young. I grew up in Surrey, and I went to university there. I'd done my undergraduate degree and my master's degree in cardiac and high altitude physiology, which is how I got involved in Ethiopia, some work in Nepal, and then with the 1,000 meters above in northern India. And then I went to medical school in Calgary and back to UBC for residency, where I did family medicine residency first, and then did some specialty training in emergency medicine. And then since then, I've been splitting my time. I mostly work as an emergency doctor in Toronto, but I do work in the intensive care unit in Surrey Memorial Hospital. And I also do some family practice here and there as well. So I try to really bridge the span of primary healthcare all the way up through to ICU, and I feel like it gives me a decent sense of how coronavirus is impacting all of those things.
So you're a very well-rounded doctor, put it this way, with your experience, international experience on top of that, and that's always good to know. You're welcome. ਜੇ ਪੰਜਾਬੀ 'ਚ ਕੁਝ ਗੱਲਾਂ ਕਰਨੀਆਂ ਤੁਸੀਂ ਪੰਜਾਬੀ 'ਚ ਵੀ ਗੱਲਾਂ ਕਰ ਸਕਦੇ ਹੋ. ਸੋ ਸਭ ਤੋਂ ਪਹਿਲਾਂ you're a frontline doctor, and first of all, we admire, respect all our frontline providers, that can doctors, nurses, health care practitioners, ambulances, paramedics, just name it, like police and whosoever. And we, on behalf of Sanjha TV, we want to really appreciate your efforts, and you are at the front lines as an emergency doctor. Tell me about your experience. ਤੁਹਾਡਾ ਹੁਣ ਤੱਕ ਜਿਹੜਾ ਹੈਗਾ ਆ, ਤੁਹਾਡਾ ਕੀ ਐਕਸਪੀਰੀਅੰਸ ਹੈ, ਤੇ ਤੁਸੀਂ ਜਦੋਂ ਹਸਪੀਟਲ ਜਾਂਦੇ ਹੋ ਤੁਹਾਨੂੰ ਡਰ ਨਹੀਂ ਲੱਗਦਾ ਵੀ you can might come across the virus?
Yeah, I mean, ਥੋੜਾ ਡਰ ਤਾਂ ਲੱਗਦਾ ਹੈ. Of course, when you go in, this is new for everybody. It's scary for everybody. And ਜਦੋਂ ਅਸੀਂ ਜਾਂਦੇ ਆ, ਪਹਿਲਾਂ there was problems with PPE. People were very concerned that there might not be enough. So that's personal protective equipment. I think it's always a concern. Even now, we know that we're a high-risk group. We know that we have to do the work that we do to keep everybody safe. But obviously you worry about your families, you worry about contamination and spreading that to people you love at home. It's not a worry that goes away. It happens today. I have shifts coming up. I'll worry about it when I come home. You do what you can, but I think all of us understand it's sort of a responsibility we accept to try and help people.
So, doctor, how you do that? Like, you know, you have a spouse at home, you come home, you live in a small place. How you do that when you go and when you come back, especially?
I think the biggest thing is when you come back. So when you're at work, the important thing is making sure you use the appropriate PPE, using the masks, the gowns, the face shields appropriately. There's a lot around that. So there's, when we're doing certain procedures in the emergency department, it requires different equipment than we would usually use. But anyway, you take the precautions at work. When you come home, it's really a matter of whatever clothes you had got to be washed separately, immediately. You sort of shower as soon as you're back. You wash your hands frequently and really limit any interaction with anything else you do as soon as you step inside the house. I think if anything, it requires just a change in the way you think, that you sort of start picturing yourself as being someone that could be contaminated and infecting other people. And so you sort of take it very seriously. To take those precautions when you get home. And beyond that, there's not much you can do. I live in a fairly small apartment downtown. It's not like I can quarantine away, but all I can do, you know, there's not much space to hide. So really,
how long you stay away from Nidhi when when you come and you change and wash yourself? You still take some time before you start communication with her?
So I will do, as soon as I come back, clothes kind of go to one separate corner, shoes off there. And the first thing I'm going to do is wash my hands, shower, and sort of put the clothes somewhere else where I will wash them separately. And then after that, once you've sort of washed appropriately, most of the contamination risk is gone. I mean, for the general public, if you're out and about, you're coming back, the first thing you really should be doing is washing your hands. It is probably the best thing you can do to limit contamination throughout the household.
So that was my next question anyways. So that's your personal experience. What do you do and what do you tell? Can we, Indy, start with the stats right now, where we stand in Canada right now? I think it's touching 3 million worldwide, and it's a pretty large numbers. America's numbers are pretty high, over 250,000 of people died already. What kind of numbers we have for Canada?
So, yeah, as you mentioned, so the numbers, it's almost reached 4 million. I think we were at 3.9 million cases worldwide today.
Oh, wow.
So it's spread, obviously, quite drastically. Canada, I should say off the bat, Canada, I think, has done a reasonably good job with this. And I think we can be proud of the public health systems that we have, but especially the teams, the primary care infrastructure we have. I think they've done a reasonably good job. In Canada, I think as of today, we had 67,000 cases, just under 5,000 deaths. Most of these are actually in Ontario and Quebec. So Ontario and Quebec account for about 56,000 of the 67,000. The vast majority of the cases are in these two provinces. And BC is actually doing quite well. BC, I think, had a total of just over 2,000 cases as of today. I think there's 127 deaths. So just for perspective, there have been more deaths in Quebec than there have been cases in all of BC. So I think by and large, we're doing well, especially when you compare to America. So America has 1.3 million cases and about 77,000 deaths. There are more deaths from COVID in America than there are cases of COVID in Canada.
So, let's talk about Canada first, and then we will compare with America. Why is the reason that BC have a lower cases compared to Ontario and Quebec? What is the fundamental? ਇਹਦੇ ਪਿੱਛੇ ਗੱਲ ਕੀ ਹੈਗੀ ਹੈ? ਉੱਥੇ ਜ਼ਿਆਦਾ ਕੇਸ ਕਿਉਂ ਹੈ?
ਗੱਲ ਤਾਂ ਥੋੜਾ complex ਹੈ. I mean, the simple thing is that when you compare, so let's just talk about Canada first, between provinces.
Yes.
Quebec has the most, followed by Ontario, and like I said, those two provinces account for the most cases in the country. Now, obviously, the populations of these two provinces is also the highest, but it's also the cases here are disproportionate to the number of people that live there. Quebec, again, there's lots of layers to this, but Quebec has done more widespread testing than most other provinces. So we would expect that their caseload looks higher. What we're probably seeing in Ontario and Quebec especially is that a lot of our cases come from, a lot of the deaths, I should say, have come from long-term care facilities. And although we see something similar in BC, we don't see it to the same extent. So something like 82% of all the deaths in the country have been due to people in long-term care facilities. And then this is, these residents only account for 1% of the population. BC initially, if you remember right, actually the numbers didn't look so good at the beginning. And it's only after they started to clamp down on social distancing measures, and I think the public really brought into it, that we start to see this flattening of the curve, and on a trajectory now that is really more like Australia and New Zealand than it is other parts of the country. But it's a lot of layers that go into this, Masajia. I mean, it's a complex problem.
So Indy, comparing that, obviously they have a larger population, and going back to your observation that there was more testing done in Quebec, and there is some rumors or that in BC the numbers are lower. The one reason could be there is not enough testing done. Is that true, or?
I think that's partly true. BC, as of the end of April, I think on the 24th or the 26th, it expanded its testing criteria. So now it does include general public who have symptoms of COVID and want to get tested. They can get tested now. Obviously, that was different than before. We were worried about availability of the swab, so we weren't doing that. So that will change the number of cases. You're going to find that there are more cases that probably come up, but I don't think it accounts for the whole thing. I think even once BC is done with its surveillance testing, it's still going to have a lower number of coronavirus cases relative to the population compared to Quebec. I think there's a lot more that gets into it, and I don't think we have the answers yet. Okay,
so you brought up the word flattening of the curve is pretty common nowadays. Simple layman ਦੀ language ਦੇ ਵਿੱਚ flattening the curve, ਇਹ ਜਿਹੜੇ ਆਪਣੇ viewers ਆ ਉਹਨਾਂ ਨੂੰ explain ਕਰੋ ਤੁਸੀਂ ਵੀ ਇਹਦਾ ਕੀ ਮਤਲਬ ਹੈ?
Flattening of the curve ਹੁੰਦਾ is when what you're trying to do in pandemics like this is that if everybody gets infected by the condition at the same time, we overrun the healthcare system. We run out of ventilators, we run out of ICU beds, okay? The idea of flattening the curve is to reduce the number of infected cases, infected people at any one time. And so if you social distance, for example, it takes longer for the number of people that are going to get infected in total to reach that point. And what that does is it gives us time to get the supplies we need, to prepare the hospitals for these things, to set up separate assessment zones. Flattening the curve, it doesn't mean that the total number of people infected is less. All it does is it takes that total number and distributes them over a longer time. And that longer time gives us time to prepare. That's what flattening the curve means.
So basically, they're saying in Canada, we are at a point where they say it's flattening the curve, specifically in British Columbia. That means, are they okay to open up now some businesses? And what are your take on that? Or we should be careful?
We always have to be careful. What they mean in that regard is that, so when cases start, because this is it's a new virus, nobody's ever seen this before. It means everybody on the planet's susceptible to it. So when people have, when you have a population that's openly susceptible to this, anybody can get infected, you normally see this rise, this exponential rise of cases. That's what overwhelms our health systems. That's when we run into trouble. That's when we have a situation like New York. What they do is they track to see that the cases are going up, and when they say it's flattening, they're really seeing that we're not seeing an exponential rise in the cases anymore. So when that happens, the public health officials are monitoring this very closely on a day-by-day basis. The other problem, obviously, to all this is we've been talking about the medical aspect, but there's a whole economic side to this, all right? 2 million jobs were lost in April alone in Canada. It's 14 or 15% unemployment rate in America right now. We have to open up economies. We have to sort of ease off restrictions at some point. I think in BC, you've probably reached a point where it's reasonable to do so. We have to be careful, though. This does not mean coronavirus is over. this will not be over until there's a virus or until we have significant community immunity. We still have to be careful, but it means we can ease some of the restrictions. And what will happen is they'll keep a very close eye. If the numbers start to rise too fast, if our ICU beds are filling up, then they'll put the quarantine restrictions back again. And that's what we're going to be looking at for the next while.
So, Doctor, can you please explain our viewers that what is COVID-19 and how it is different than the previous epidemics or pandemics, whatever you want to call him? You can explain a little bit of that too, like SARS, H1N1, Zika. There are a bunch of viruses came and gone and never was a big fuss like now. Tell our viewers in the medical terms, why is it so dangerous?
So coronavirus is a virus that has existed as a family of viruses. It's existed for a long time. Coronavirus is one of the many viruses that you might get that causes the common cold. Now, COVID-19 is a specific strain. It's a new strain that mutated from animals to humans. We think sometime in December, that started in Wuhan in China. The issue when you have a new strain of a virus is that unlike other viruses we're exposed to as children, we develop some immunity to them. Same with the flu. It's why we have a cold. Most people don't die of a cold. You have some symptoms for a while, maybe for a week or so, and then you get better. When a new virus pops up like this, and this has happened a few times, so SARS, you mentioned, MERS, we'll talk about that in a minute. With new viruses, the issue is that we have no immunity. Okay, there's nothing in us that will help, other than some passive mechanisms. We have no specific way to deal with this virus. And so what happens is people who have lots of comorbidities, kidney issues, heart issues, they're at high risk. They can get sick enough that a virus like this can kill them. Now, what specifically is concerning about coronavirus is just how easy it is to infect people. So if you look at SARS, for example, it's something like 44 people died of SARS in the whole country. Okay, we have well exceeded that. The transmission rate of coronavirus is much higher than SARS was. SARS was a problem of healthcare professionals mostly. But coronavirus seems to transmit so easily, whether it's through droplets, whether it's through something you've touched that then somebody else then touches afterwards, a fomite transmission. It seems to transmit very easily. And so the problem is, even though in and of itself, coronavirus it doesn't have a high case fatality rate, meaning that if an individual, a young, healthy person gets coronavirus today, their chance of dying is still relatively low. It's higher than the flu, but it's not higher than measles or Ebola or something like that. The problem is the number of people that will ultimately be infected. There are 4 million people have been infected already of coronavirus, and we haven't even been doing widespread testing. That number is going to be significantly higher. So this transmits a lot faster and a lot easier than a lot of other viruses. That's what makes it dangerous.
So, Dr. Sahota, how well prepared ਆਪਾਂ ਕੈਨੇਡਾ ਦੇ ਵਿੱਚ when it comes to personal protective equipment, PPE we call it, ventilators, masks, and you're in the front line there. ਆਪਾਂ ਕੈਨੇਡਾ ਦੇ ਵਿੱਚ ਮਤਲਬ relatively and provinces ਕਿੰਨੇ ਕੁ ਆਪਾਂ prepared ਹੈ?
See, we were quite well prepared, I would say. I think if I look at the emergency department I work in, we obviously have to be a bit careful to think about we might need these moving forward, but there's not been a shortage. It's not been like what we've seen in America, what we saw in Italy before, or even in the UK, where people are having to use alternate means or reuse their masks. We haven't had to do that here. So I think Canada did a very reasonable job sourcing the equipment and providing it to frontline staff. In terms of ventilators, it's the same thing. I think because of the good public health policies, we did physical distancing measures fairly early. We never really saw that spike. We never saw that surge of cases that we saw, say, in New York. And it's only when you have the surge of cases you have to worry about not having enough mechanical ventilators, for example. Again, if you flatten the curve, and that's all public health measures, if you flatten the curve, you can limit the number of people who all get sick at one time. that's when you run into problem. A hospital, let's say you have 100 ventilators in your hospital. Now, if you have 1,000 people that are going to get sick with COVID, who are going to need a ventilator. Now, if all 1,000 people come in the first week, you're going to be short 900 ventilators. If you spread them out over 6 months, people who are on a ventilator, eventually they're going to get off the ventilator, it becomes available again. So then we still have that available to use. We can manage, and ventilator is one piece of that, but ICU beds, staff, whether it's nurses, doctors, respiratory therapists, these are all finite resources. We can't just create more straight away if we want them. So spreading that sort of distribution is what's really helped us here in Canada. And from a PPE perspective, I think we've done a reasonable job sourcing them, and we've had access to what we need. And I can speak to that from sort of Vancouver and Toronto, but I think it's been the case across the country.
So Indy, my next question will be, America and Canada, why we are relatively did a better job compared to America, and especially the battleground is New York. It's so unfortunate. Losing a one death, like in your profession and in general, is a big enough a deal. Yeah. Like losing that many people, where America missed the boat.
Again, there's probably a lot to that, but I think one of the many things is probably not focusing enough on the little evidence that we had that physical distancing worked early. Right? If you think about it, when this blew up, it sort of started in China. We had an outbreak in Iran, then it went to Italy, and then we saw it spread to Europe. Then it sort of made its way over, and so we had a bit of time to prepare. Right? It's not like we were China having to figure this out as it went on. But I think the political leadership there has some part to play in this. Most of what we were hearing from President Trump had more to do with things like hydroxychloroquine. Now he's talking about bleach and different light therapies. I mean, I'm not going to give him too much airtime, but it distracts us from what's really going to help. And now you're seeing in states like Georgia, I think there were 9 states that are due to reopen. I mean, the US is the global hotspot. But public health measures there, like anything, has become very politicized. There's sort of a red way and a blue way of doing things.
Yes.
And public health shouldn't be like that. Public health should be grounded in the best science that we have. It shouldn't matter what your political persuasion is. I'm not saying that science is always right. We're figuring this out as we go. But it's the best that we have. And so I think what we see there, New York obviously is a very cosmopolitan place. It's very heavily crowded. So I'm not saying that's the only reason, but I think that's a big reason. It distracted people from doing what we needed to do early on, which was contain this, do the physical distancing, the self-isolation, so we don't spike. And it's really unfortunate what we saw happen in New York because of that, and all the deaths because of that.
Yeah, so we're talking about the political environment, the red states versus blue states. And on top of that, you being in the trenches in this Center for Disease Control. And it's such an unfortunate, we don't want to or need to make a political statement, but they were pushed aside versus in Canada, they're equal partners in this battle.
Yeah. And you can probably speak to the political side better than I can, but you notice the type, but the language that's used, right? When Prime Minister Trudeau is doing his daily address, it's acknowledging that the public health agencies of Canada, the institutions that we have created to keep us safe, well, it's their job to do that, and we have to give them the space to do that. And he acknowledges that. And I think that's for the betterment of all of us. Now, this is just a piece of this, to be honest with you, for lots of reasons. Canada is probably in a slightly better position. We have slightly less inequity, social and economic inequity. We have better primary health systems that support the vulnerable and the marginalized. So there's probably lots of layers to this. But certainly, I think political leadership has a lot to do.
So, Dr. Sahota, ਤੁਸੀਂ ਬਹੁਤ ਸੋਹਣੀ ਇਨਫੋਰਮੇਸ਼ਨ ਦਿੱਤੀ ਹੈ ਤੇ ਅਸੀਂ 5 ਮਿੰਟ ਦਾ ਕਮਰਸ਼ੀਅਲ ਬ੍ਰੇਕ ਲੈ ਕੇ ਪਰਤ ਕੇ ਆਉਨੇ ਆ ਤੇ ਸਾਡੀ ਗੱਲ ਇਸੇ ਤਰ੍ਹਾਂ ਹੀ ਡਾਕਟਰ ਇੰਦੀ ਸਹੋਤਾ ਜਿਹੜੇ ਕਿ ਐਮਰਜੈਂਸੀ ਡਾਕਟਰ ਹੈਗੇ ਟੋਰਾਂਟੋ ਦੇ ਵਿੱਚ, ਉਹਨਾਂ ਨਾਲ ਇਸ ਤਰ੍ਹਾਂ ਸਾਡੀ ਗੱਲਬਾਤ ਜਾਰੀ ਰਹੂਗੀ ਤੇ ਇਹਨਾਂ ਤੋਂ ਸਾਰੀ ਇਨਫੋਰਮੇਸ਼ਨ ਜਿਹੜੀ ਹੈ ਸੀਜੇ ਸਿੱਧੂ ਸ਼ੋਅ ਦੇ ਵਿੱਚ ਸਾਡੀ ਅੱਜ ਗੱਲਬਾਤ ਚੱਲ ਰਹੀ ਹੈ। ਡਾਕਟਰ ਇੰਦੀ ਸਹੋਤਾ ਜਿਹੜੇ ਕਿ ਐਮਰਜੈਂਸੀ ਡਾਕਟਰ ਹੈਗੇ ਆ ਟੋਰਾਂਟੋ ਦੇ ਵਿੱਚ ਸਰੀ ਮੈਮੋਰੀਅਲ ਹਸਪੀਟਲ 'ਚ ਵੀ ਇਹ ਕੰਮ ਕਰਦੇ ਆ। COVID-19 ਦੇ ਬਾਰੇ ਇਹ ਫਰੰਟ ਲਾਈਨ ਡਾਕਟਰ ਕਰਕੇ ਇਹਨਾਂ ਨਾਲ ਸਾਡੀ ਗੱਲਬਾਤ ਚੱਲ ਰਹੀ ਹੈ ਤੇ ਇਹਨਾਂ ਤੋਂ ਇਨਫੋਰਮੇਸ਼ਨ ਕਾਫੀ ਅਸੀਂ ਲੈ ਰਹੇ ਹਾਂ। ਅੱਜ ਅਸੀਂ ਤੁਹਾਡੀ ਫੋਨ ਕਾਲਸ ਨਹੀਂ ਲੈ ਸਕਦੇ and in the future we will make sure that take your phone calls. So welcome back, Dr. Sahota.
Thank you.
So COVID-19 ਦਾ ਜਿਹੜੀ ਇਹ ਨਾਮੁਰਾਦ ਬਿਮਾਰੀ ਜਿਹੜੀ ਹੈ ਅਨਫੋਰਚੂਨੇਟ ਐਂਡ ਇਹਦਾ ਹਲੇ ਤੱਕ ਕੋਈ ਵੈਕਸੀਨ ਨਹੀਂ ਨਿਕਲਿਆ। ਹਾਲਾਂਕਿ ਕਾਫੀ ਇੰਟਰਨੈਸ਼ਨਲ ਪੱਧਰ ਤੇ research ਚੱਲ ਰਹੀ ਹੈ। ਮੇਰੇ ਖਿਆਲ Pfizer and Germany collaborating and a bunch of other Canada doing a good job in a research. So where we stand on that vaccine or medication or some sort of solution?
Yeah, it's mostly bad news, I'm afraid. The vaccine is going to be very important in all this. So unless we have enough infections throughout the community that we develop some sort of herd immunity or community immunity, we're going to need a vaccine before this all ends, before we can go traveling internationally and going about life as usual. There are lots and lots of groups that are trying to work on this now, all around the world. I think one that got a lot of press recently was a group in Oxford that said they might be able to develop one as soon as the fall. I mean, if that's possible, that would be fantastic. I think that's probably a bit optimistic. The thing is, these things take time. So even if you develop the vaccine, you then have to test it. You have to test to make sure that it works. And we'll talk about why that's important in a minute. But not only that, even if you figure out that it does work and it works well, you then have to scale up the manufacture and you have to distribute this to billions of people around the world. These things take time. So even if you had a vaccine today, it's not like you would have it injected into you by tomorrow. Okay, so but the vaccine is very important. Now, in terms of treatments, I think a lot of people remember early on we were talking a lot about hydroxychloroquine or chloroquine, one of the malaria treatments, then this other one, remdesivir, it's an antiviral. And President Trump again was talking a lot about especially hydroxychloroquine. So initially the studies, this very small study that came out of France that suggested that it might work as a single center study. And so I got a lot of press attention. People were starting to use this. New studies that actually just came out more recently, bigger randomized control trials, show that both of these medications probably don't do a whole lot. So we are actually stuck right now with no real treatment for coronavirus. If people get sick enough that they have to come to hospital, the best we can do is supportive treatment, whether that's supplemental oxygen, treating secondary bacterial pneumonia, and if they have to use a mechanical ventilator, then obviously some of the ventilator settings. But really, right now, there's not a treatment for this.
So basically, are you using like experimentally some sort of like hydroxychloroquine, or sometimes they said that at old times the TB medication that used to be in a third world countries, India and other countries, and that might have a time and place in these kind of things. So what sort of medication is coming out in the front and center as a cure, not as a political statement?
So there's lots of things that are being trialed. Hydroxychloroquine I talked about, some of the antiviral medications. There's a few different specialized biologic medications that they've been trying. They're all either in the trial phase or the recent trials have showed that they don't work. But obviously we continue to try and see if we can develop new treatments. Realistically, I don't think we're going to find a cure. I don't think we'll find a medication that necessarily cures this, is my personal viewpoint. I mean, the vaccine is going to be the best chance we probably have outside of widespread infection and community immunity.
So having said that, Indy, that's kind of scary in a lot of ways. If and I'm talking to my friend doctors in America as well, the process is 12 to 18 months. Even they try to push it early, and FDA approval, the side effects and all that kind of drama goes around it. Well, not a drama, it's a public health issue. And it can be serious if the side effects are worse than the benefit. So, so what do you think this social distancing and the traveling and all these kind of things, is there any timeline in your mind that, you know, international travel, or how long it will last, Indy?
It's nobody can give you a real accurate number on this because nobody really knows. What I can say is international travel will be one of the last things that we're able to do. So if you look at now, BC, for example, has rolled out its reopening plan. So we were in phase 1 previously, meaning only really essential workers were able to work. I think we all sort of know about that and have heard about that. The next phase, phase 2, that's going to come about, which is the one that they're going to start hopefully soon, is going to allow for a slightly more number of businesses to start opening again. We'll start having elective surgeries. Some allied health professionals, things like dentists, will open again. So in a staged approach, we'll see that. Then what they're going to do is they're going to keep a very close eye on what's happening with infection rates. So sometimes you may have heard people are saying that there could be a second wave in the fall. What they mean by that is if we do these things now, we slightly loosen restrictions. If the case number starts to rise rapidly again, that's what they're referring to as a second wave. Okay. And they predict that we could end up seeing that sometime in the fall if we started to reopen things. Now, if that happens, what will happen is we'll go back to essentially phase 1. We'll have to self-isolate again. But if we go through phase 2 and the numbers are reasonable, we're not over capacity in the ICU or in the emergency department, they'll step it up to phase 3 and then on to phase 4. Phase 3, for example, would include things like opening up schools. So if things go to plan, September, we could see reopening of kindergarten to grade 12. But again, it all depends on how we do in the next phase. But large-scale mass gatherings, international travel, these are all going to be a phase 4. That will be the last phase. And so we won't be doing that anytime soon.
And that might be 2 years, 3 years, who knows?
It's really hard to say. I mean, most people right now would predict maybe we're looking at around the year mark, but it depends on how we do. Now, the problem is if you imagine we open up our borders now, let's say BC, for example, right? BC has very few cases. They're moving into a reopening phase. Now, imagine if they open their borders to the States, where you have the number of cases that you have there. And that's just an example. Right?
Yes.
We're at high risk then of sort of seeing that slope rise rapidly. Okay, and we're seeing this in countries now like sort of Singapore, China, where they had sort of allowed for some more local travel or even inter-provincial, interstate travel, and these cases start to rise again. But what we're going to see is really keeping a close eye on the numbers. If the numbers don't go up too high, then we'll do a stage-wise opening, which I think is the safest way to do it. But international travel will be somewhere towards the end because every country is dealing with this differently. We're neighbors with America, and Canada's doing reasonably well in America as the global hotspot, right? We see this all over the place. Germany has done reasonably well. It's very close to Italy, which was a global hotspot. The international travel piece, it complicates things because every country is responsible for their own public health measures.
Another, Dr. Sahota, the very sensitive issue, and there is a lot of rumors around it. It started in Wuhan and started with the, I don't know, they're saying from the bats and then going to the meat and transmitted, and they able to contain it very quickly. A lot of theories are going around. Is it China played some, not a professional job, or World Health Organization took a little bit longer to tell the Western world what's going on? What are your take on these controversial issues going around?
Mm-hmm. I think we have to be very careful, CJ, is that there's lots of misinformation, lots of conspiracy around this, okay? Because there's a lot that we don't know, quite frankly. What I can say is, initially, when we look at Wuhan, for example, when the cases started to rise, the Chinese government, because of the way the government runs, they have more direct control. were able to actually impose quarantine on large scale, like on the city level, then the provincial level, very quickly. So I think we owe a lot to the fact that they were able to do that, to contain the spread, which could have been a lot faster. There's lots of conspiracy theories around, could they have done better? There's even things about, was this designed by the Chinese government to spread? I mean, I don't think there's any logical basis to any of this. Could we have done better? We won't know. I think, in a few years' time, we can look back, and as a not as a country, but even as an international community, we're going to look back and see where could we have done things better. I'll tell you now, a lot of the approach that we've taken in Canada with coronavirus is from the mistakes that we made with SARS. All right, we learned from our mistakes, and I think a lot of these things about how China, how they reacted initially, could they have done better? Could the WHO have done a little better? I mean, I think by and large they've done pretty good jobs. We all probably could improve, but we're not going to know this until this is all over and we can sit back and see, look at the data.
Another very burning issue is long-term care. People are older, have a pre-existing condition. I think over 50% of the deaths in Canada happened in that environment. And then we will talk about a little bit about the meat plants and the prisons. Maybe because of the large number of people in a close proximity, that might be the reason. But are we failed in a long-term care by the inspections, be proactive as a medical professional? What are your take on these issues?
So I think the one criticism you could make of Canada's reaction is that so many of our deaths have come from long-term care residents. So it's just over 80% of the deaths have come from long-term care residents. And as I mentioned before, they account for about 1%, maybe less than 1% of Canada's population, so disproportionately affected. Now, obviously, by definition, these are sicker, more vulnerable patients. They're going to be older, they're going to have other comorbidities, right? So we expect the number to be a bit higher. But even when you compare it to other countries around the world, the number of cases we've had in long-term care facilities, especially in Ontario and Quebec, is really disproportionate. And I think when the dust settles on this, we're going to have a lot of thinking to do about why this happened. Some of the theories now is obviously long-term care. A lot of our long-term care focus has been on the building of facilities. We build facilities. When people get sick enough, they go to these facilities, they stay there. So then you've got this sort of area where you've got a lot of vulnerable people in an enclosed space. So then you add to that, we've got personal support workers, we've got other healthcare workers in there who are paid so low that they have to work multiple jobs, which means they have to work within different facilities, which is going to increase the risk of contamination. And do they have the right PPE available? A lot of these are private facilities. Maybe they haven't been quite as open about their needs because obviously they have a business that they have to protect. So I think for a lot of reasons, we're going to have to sit back afterwards as a country and think whether this is the right model. Compare it to a place like Denmark, for example. 30 years ago, they switched to trying to improve services for people to stay at home or stay in the community instead of having everybody come to a long-term care facility. The benefit from that obviously is not like prisons, for example. You're not putting a lot of vulnerable people in a closed space. So in Canada, yeah, we have a disproportionate number of long-term care deaths due to COVID.
And the other issue is obviously, the meat plants. Sometimes people have a confusion, and can be transmitted from person to person to the meat itself, because there is large cases in Canada and also in America.
Yeah, so our understanding right now suggests that that's not the case. So we know obviously of person-to-person transmission, either through droplets, so if people are breathing in close proximity or talking in close proximity, from contaminated objects. So if you've touched something, plastic surfaces, stainless steel surfaces, we know the virus can live for somewhere up to 72 hours. So that's a possibility. But I think what we're seeing in Cargill, I mean, I don't know the situation that well, but it was probably person-to-person transmission in enclosed spaces that caused that, rather than transmission through the actual meat itself.
And briefly, share with our viewers the transmission, how that there is some rumors about can it transmit in a air as well. There is some possibility lately coming out. If you're an elevator and you sneeze, then that sneeze probably stay there in a air for a little bit. So what is your take on that? Can it go in air? If it does, for how long?
Yeah, this is a very interesting question, and it was something that was very controversial and probably still is a little bit controversial now. Early on, I think we all understood this as being what we call a droplet condition, okay? So that's going to be sort of secretions within the mouth. That could include sneezing, for example. But what we understand of droplets is that once you've sneezed, it kind of falls to the floor fairly quickly, so it shouldn't linger in the air very long. But what we're understanding more and more is that it probably does linger in enclosed spaces for longer. So if you did sneeze in an elevator, for example, without a mask on, it's quite possible that you could be infected that way. Now, if you're outside in very well ventilated areas, that's much less likely, okay, because it disperses into the air very quickly. But in enclosed spaces, especially things like sneezing, because you project a lot of droplets out into the atmosphere, the question gets interesting when you start to think, okay, what about breathing? What about talking? What if I get too close to somebody? And I don't think we have really good data on that yet. But I think one of the things that has been recommended, and early on we sort of weren't doing this, is the public wearing of cloth masks to try and prevent contamination, try and prevent transmission because of these reasons.
And that was my next question anyways, about the masks. What is your take on that? People ਨੂੰ ਮਾਸਕ ਪਾਉਣਾ ਚਾਹੀਦਾ ਹੈ, ਨਹੀਂ ਪਾਉਣਾ ਚਾਹੀਦਾ, ਇਹਦੀ ਵੈਲਿਡਿਟੀ ਹੈ, ਐਡਵਾਂਟੇਜ ਵੀ ਹੈਗੀ ਹੈ ਕੋਈ ਜਾਂ ਨਹੀਂ?
Advantage to ਹੈਗੀ Billy, but the problem is that we didn't have enough of the masks. So if you imagine, you remember early on, it feels like we've been at coronavirus for years, but just 2 months ago, we talked about there was somebody put out there that it could be transmitted through GI infection, and then everybody goes out and hoards toilet paper, right? You remember that it happened for a couple of weeks. Now, imagine if people went out and did the same with masks, surgical masks that we need when we're working in the emergency department to stay safe, looking after people. That was the worry at the beginning. And that was the issue with people wearing N95 masks. N95s are very specific masks that we use for only certain procedures, even in the emergency department. The short answer is, I think now we probably have enough evidence to say people, when they're going outside, should be wearing masks, more to protect other people. But what we probably want to be very careful is that they're not using masks that we're going to need on the front line. So medical grade surgical masks or N95 filtration masks. What's probably reasonable for the public to use is going to be cloth masks, masks that you can probably even make at home or purchase. And just to form a barrier between when people are talking or sneezing when they're outside, okay? There are lots of elements to this. There's some data that suggests that if you are wearing masks, people tend to touch their face more. That's going to increase the risk of transmission. So we do have to still practice hand hygiene, wash our hands frequently, try not to touch our face. But I think cloth masks are very reasonable. We have to be very careful that we're not using surgical masks, medical masks that we need to use on the front line, because if we run out of those in the hospital, it's going to be very dangerous for the public. There'll be procedures, life-saving procedures that we just can't do anymore. And that will have very real-world effects. People won't get the treatment they need.
That's good to know for our viewers. That's a good information. You're at the front line, Indy, and you come across your colleagues and co-workers, nurses and everything. What kind of conversation and morale you have? Are they worried? Are they concerned that a death happened not too long ago, one of the healthcare workers? And what kind of, in the ICU and in your corridors when you guys talk, and how you take a breaks and coffee and tea breaks? Tell a little bit more what goes behind the scenes.
It's been interesting. It's been a very interesting time. I mean, in one hand, the fact that we're all having to deal with coronavirus, we're all there at the front line, means it builds some camaraderie, right? We sort of band together we band together dealing with this in a way. It's also very surreal, right? Like, there are so many people are passing away of this, getting very seriously sick from this. We're obviously all worried about ourselves becoming infected. We've had colleagues that have have gotten very sick or even passed away, and these can really take their toll. Add to that it's very limited what we can do in terms of helping each other out. Like, we still have to try and maintain some element of social distancing at work, even as much as we can. So I think it's been a very weird time. We have tried to sort of band together. We know we're sort of in this together, but at the same time, it's scary. It's very real when your colleagues start to get sick. And I think we all have very different ways of coping, and because of social isolation and physical distancing, it means we can't, really be there for each other in the same way we might want to, and that's tough. That's tough.
Yes, it is, and that's why our communities worldwide, especially Canada, America, they hats off to you guys being at front lines, putting your life at times in danger to save lives. That's an amazing profession that makes difference in people's lives. So I have about 5-6 minutes left, Indy. But the very most important, what people should be paying attention to, be careful, so our covers, the curve stays flat. ਇਹਦੇ ਬਾਰੇ ਤੁਹਾਡੇ ਕੀ ਜਿਹੜੀ ਆਪਣੀ ਕਮਿਊਨਿਟੀਜ਼ ਤੁਹਾਨੂੰ ਪਤਾ ਆ, ਖਾਸ ਕਰਕੇ ਆਪਣੀ ਸਾਊਥ ਏਸ਼ੀਅਨ ਕਮਿਊਨਿਟੀਜ਼, ਮੰਦਰ, ਮਸਜਿਦ, ਗੁਰਦੁਆਰੇ, ਮਤਲਬ they are pretty much closed now, and we're so used to large gathering, weddings, engagements, they all postponed or cancelled. So ਆਪਾਂ ਕਿਹੜੀਆਂ ਚੀਜ਼ਾਂ ਦਾ ਖਿਆਲ ਰੱਖਣਾ ਚਾਹੀਦਾ?
Ajay, we still have to be very careful, and I think that's the message I want to get across to everybody. Even if we go into the next phase of reopening, coronavirus hasn't gone away. It's still out there. It's still just as likely to infect people. And if we don't do a good job with maintaining some social distancing and listening to public health guidelines, we're going to go right back into where we are right now. And this thing is going to drag out longer. Mass gatherings, things like weddings, all of our ceremonies involve lots of people typically. That's sort of the type of people we are. We're not going to be doing that for some time, okay? And I think we sort of have to accept that this is going to be the new normal for a while. This is not something that's going to go away in a few months' time. And I think mentally we have to prepare ourselves for that. All the stuff that people are doing before, washing hands, trying not to touch their face, maybe wearing the masks when they're outside, limiting the number of people they gather with, these are all going to still be important things to do. But I think the big thing for us is just to really just recognize that we're in this for the long haul. This is a marathon, it's not a sprint. And our lives are going to be very different for some time now.
Oh, wow. That's good to know. So in a closing, can you tell us a little bit in a brief, summarized way, your charity, 1,000 meters above, Atma stands for, and that's your charity. And tell us the difference of the medical system in Ladakh and Ethiopia you've been to in a very summarized way. What are you planning on doing under your charity?
So the charity is Ladakh. For those of you who don't know, it's a district in northern India, and it's right next to the Tibetan border. And it's very different from other parts of India in that the population density is very low. It's sort of at high altitude. There are very few roads. There are no roads that are open year round. So they're very isolated. So we set up this organization in 2012, and what we tried to do is fund some of the healthcare programs that they have there. So some mobile medical camps by Dr. Norbu, who is a retired doctor in Ladakh. So we help fund the programs that they do to provide medical care for the Ladakhi people. And this came as an interest of mine from some work overseas. I'd worked in Ethiopia, a bit of work in India, Nepal, in South Africa. And it's really the lessons I had learned in all of those that helps drive what we're doing with Atma. But essentially, we're just trying to provide some medical care to people there that wouldn't get any otherwise. And so we feel it's very important. People are free to visit the website, 1000metersabove.org. We have lots of good information there on the programs that we do and the projects that we fund.
Thank you, Dr. Indy Sahota. It was my pleasure. We are related and so proud of you. You're at the front line. Please stay safe. And congratulate all the co-workers. We admire them on behalf of Sanjha TV. Thank you very much. You're a busy man and you got that time for us. We greatly appreciate that.
No, you're very welcome. Thank you very much for all the work you're doing to spread this awareness too. It's very important for our community.
ਸੋ ਸਾਡੀ ਅੱਜ ਗੱਲ ਚੱਲ ਰਹੀ ਸੀ ਡਾਕਟਰ ਇੰਦੀ ਸਹੋਤਾ ਜਿਹੜੇ ਕਿ ਐਮਰਜੈਂਸੀ ਡਾਕਟਰ ਟੋਰਾਂਟੋ 'ਚ ਹੈ ਸਰੀ ਮੈਮੋਰੀਅਲ ਹਸਪੀਟਲ ਵੀ ਇਹਨਾਂ ਦਾ ਕੰਮ ਇਹ ਕਰਦੇ ਹੈ ਤੇ ਹੀ ਇਜ਼ ਅ ਯੰਗ ਫਿਜ਼ੀਸ਼ੀਅਨ ਦੇ ਡੂਇੰਗ ਨਾਟ ਓਨਲੀ for glory or making money all the time. You already heard his charity 1,000 meters above.org. You can go there if you want to donate for a good cause. They are working tirelessly, and I had a chance to read about it. It's not like the normal charities. It's only the admin part is only 1%. Rest goes to work for the people who need the most. So ਇਸੇ ਤਰ੍ਹਾਂ ਹੀ ਹਰ ਹਫਤੇ CJ ਸਿੱਧੂ ਸ਼ੋਅ ਦੇ ਵਿੱਚ ਅਸੀਂ ਬਿਕਾਜ਼ ਆਫ COVID-19 ਆਈ ਐਮ ਬ੍ਰਿੰਗਿੰਗ ਮੋਰ ਡਾਕਟਰਸ ਨਾਓ ਐਂਡ ਨਹੀਂ ਤਾਂ ਆਪਣੇ ਪੋਲੀਟੀਸ਼ੀਅਨ ਉਹਨਾਂ ਤੋਂ ਵੀ ਇਨਫੋਰਮੇਸ਼ਨ ਜ਼ਰੂਰੀ ਹੈ ਉਸ ਦੇ ਨਾਲ ਜਿਹੜੇ ਕਮਿਊਨਿਟੀ ਐਕਟਿਵਿਸਟ ਹੈ ਉਹਦੇ ਬਾਰੇ ਵੀ ਗੱਲ ਕਰਨੀ ਜ਼ਰੂਰੀ ਹੈ ਅੱਜ ਥੋੜ੍ਹਾ ਟਾਈਮ ਕਰਕੇ ਅਸੀਂ ਮੈਂਟਲ ਹੈਲਥ ਸਪਾਊਸਲ ਅਬਿਊਜ਼ ਤੇ ਉਹਨਾਂ ਇਸ਼ੂਜ਼ ਦੇ ਬਾਰੇ ਨਹੀਂ ਗੱਲ ਕਰ ਸਕੇ ਸੋ ਇਸ ਮਾਮਲਿਆਂ ਦੇ ਜਿਹੜੇ ਐਕਸਪਰਟ ਹੈ ਨੈਕਸਟ ਟਾਈਮ ਤੁਹਾਡੇ ਨਾਲ ਗੱਲਬਾਤ ਕਰਾਵਾਂਗੇ ਧੰਨਵਾਦ ਪਲੀਜ਼ ਲਿਸਨ ਟੂ ਥੀਸ ਡਾਕਟਰਸ pay attention, stay safe, wash your hand, don't touch your face, keep that 2-meter distance, 6 feet difference, and stay away from the large crowds. ਜਿੰਨਾ ਆਪਾਂ ਬਚਾ ਰੱਖਾਂਗੇ ਜਿਵੇਂ ਪੰਜਾਬੀ ਚ ਕਹਿੰਦੇ ਆ ਬਚਾਅ ਚ ਹੀ ਬਚਾਅ ਹੈ ਧੰਨਵਾਦ ਰੱਬ ਰੱਖਾ